Welcome everyone. I hope I'm audible right now. And okay, let me share my screen. And then Welcome everyone. I am Naveed Syed. I am a third-year medical student, and today I'm going to give the lecture or the call session on pulmonary circulation, gas transport, and hypoxemia. So let's begin. Before we start, obviously, all of these slides are adapted from Dr. Sham's slides, so all credits to him. And I would like to give a disclaimer for my session, especially. I am someone who likes to teach through a more of a conceptual manner, through understanding rather than just, getting facts. So I would like you to use this as an understanding tool and always go through your lecture slides, because I'm not the one putting questions on the exam, right? It's going to be Dr. Shams. So at the end of the day, he's the one who's deciding it. So make sure you're thorough with whatever he has mentioned in his slides. And if I have missed something, although I've tried to cover whatever he covers in his lecture, always cross-reference with your main lecture slides and use this as a conceptual tool rather than just for memorization. So the first lecture we're going to cover, it's the lecture number 24 from your syllabus, and that is the pulmonary gas exchange. Okay. So before we get into the detail of the pulmonary circulation, we have to get an overview, right? We have to get an overview of the pulmonary circulation. Obviously, you've heard this about 100 times in cardio, but let's go over it again. Obviously, our systemic, we have two types of circulation. One is the systemic, which you can see here, and the other one is the pulmonary circulation, right? And the other one is the pulmonary circulation. Okay, now the systemic circulation is a high pressure circulation because we know about the systolic pressure is about 120 over 80 and so on, right? So it's going to start from the left ventricle, it's going to move into the aorta, and then it's going to go into your systemic circulation, into your tissues, and it's going to return via the vena cava into the right atrium of the heart. Now, the system is a high pressure system with the systolic being 120 or diastolic about being 82. And finally, the pressure in the right atrium is about 4 millimeters of mercury. Why am I mentioning these two pressures? Because we know that blood flow depends on the difference in the pressure, or it depends on the pressure gradient, right? That is delta P, okay? And that is important for maintaining normal flow of blood. And what would be the pressure difference here? It will be about 120 minus 4, right? It will be about 116, which is a quite large pressure difference. And that accounts for a very high flow of blood, which goes through the systemic circulation. Once it enters the right side of the heart, it enters into the right atrium. Then from there, it will go to the right ventricle. Now, where does it go from the right ventricle? It goes into the pulmonary circulation, right? It reaches to the pulmonary artery and then goes to the alveoli, and the pulmonary vein will return it back into the left atrium. Now, the pressure in the pulmonary artery is 20 over 10. And in the left atrium is 6 over 8, which is a really low pressure system. If we calculate the delta P here, or the pressure gradient here, is going to be 20, let's say minus 8, which is about 12. So we are talking about 116 millimeters of mercury in the systemic circulation and only 12 millimeters of mercury in the pulmonary circulation. So it's a very low pressure system. Okay, let me ask you this. We have the cardiac output. Whenever we talk about the cardiac output, we're talking about the blood which is being pumped out by the left ventricle. And this amount of blood which is being pumped out is the cardiac output. Now, will the cardiac output be the same for the left ventricle and for the right ventricle? Is it going to be the same on both sides? The answer is yes, it has to be, right? Because if the right ventricle pumps lower amount of blood than the left ventricle, then the left ventricle will also pump less amount of blood because it's not receiving this the same amount. So it's going to receive a lesser amount, so it should have a lesser cardiac output. But that's not the case. That's why the cardiac output is the same. Now let's go back to the formula of cardiac output, right? The formula of cardiac output is delta P, or one of the formula, which is the pressure gradient, divided by the R, which is the resistance, right? And delta P is the pressure gradient and R is the resistance. We said for systemic circulation, the delta P is high and the resistance is also quite high. But here in the pulmonary circulation, we said that the cardiac output would be the same, but we said that the delta P is really low, it's really small. Then logically speaking, should my resistance be really high or really low to maintain the same cardiac output? It's going to be really low, right? And that is really important because that low resistance would mean that the pressure would also roll, right? Because we know that if vessels have high resistance, they're also going to have high pressure within them, right? So here, because the resistance is low, the pressure or the blood pressure as it moves through these pulmonary circulation is also going to be really low. And obviously we have talked about it, right? But now we've just proved this more mathematically. So the average pressure, let's say, is about 14 millimeters of mercury. That's a very good reference, right? Why is it important to talk about this pressure, right? Because the pressure is really low within the circulation, which means it's more susceptible to changes in pressure from outside or the external pressure. What do I mean? Well, here's the thing. Now, you learned in cardio and you learned in earlier pulmonary lectures about the transmural pressure, right? The pressure across the wall and so on. Again, just to reiterate, the transmural pressure is the pressure from inside minus the pressure from outside. Okay. All right. Let's take the example of systemic circulation first. We said the systemic circulation has a high pressure, right? Let's take this. Let's say this is the left side, which is for the systemic circulation. Okay. And the pressure from the inside is 100 millimeters of mercury, which is a this is a very realistic pressure which can be present within the systemic circulation, which is 100 millimeters of mercury. Let's say it's 100 millimeters of mercury from inside. And let's say, for the sake of this example, right, for the sake of illustration, the external pressure on the aorta or whatever vessel we are looking at is 10 millimeters of mercury. Now, what would be the transmural pressure? It will be the pressure inside minus outside, which would be about 90 millimeters of mercury, right? So the 90 millimeters of mercury is the pressure which is being exerted from inside. Hello? Okay, that makes sense. Now let's take the example of pulmonary circulation. We said that the average pressure is 14. The average pressure within it is 14 millimeters of mercury, right? The same example for the external surface is the pressure on the external surface from whatever external pressure, it's 10 millimeters of mercury. So what is the transmural pressure here? It's about 4 millimeters of mercury. 4 millimeters of mercury. So you see the difference in transmural pressure? Here it's 4 millimeters of mercury and there it's 90 millimeters of mercury. So if I were to increase the external pressure in the systemic circulation from 10 to 20, okay, fine, it's going to drop to 80. Not much of a difference. But here, if I increase it by 10, it's going to go into -4, which means it will be able to compress the vessel. And this is what we mean. It's more susceptible to changes in transmural pressure. An increase in transmural pressure is going to result in distension of the vessel. It's going to expand. Why? Because it has a higher pressure from inside. If the pressure outside is low, that is the transmural pressure drops, then in that case, my vessel will become narrow. You have to keep this in mind. Now, let's go over the classification of vessels, right? Based on the external pressure that we talked about, the vessels can be classified into 3 types. extrapulmonary vessel, the bronchial vessel, and the alveolar capillaries. Let's go into them one by one. So first of all, sorry, does somebody have a question? Okay. Okay. So the extrapulmonary vessels, these extrapulmonary vessels, when we talk about them, these are essentially the vessels which sit in your mediastinum. So the inferior vena cava, superior vena cava, and so on. Now, what is the pressure the mediastinum is subjected to? It's going to be the pleural pressure, right? The pressure which is exerted by the pleura which surrounds your lungs. So that is the pressure which the superior vena cava and inferior vena cava are going to face. Okay, now what's going to happen to this pleural pressure during inspiration? During inspiration. When you inspire, what's going to happen to your chest cavity? It's going to expand, right? The volume is going to increase and the pressure is going to decrease. So the pleural pressure during inspiration decreases. So what will happen to the transmural pressure? It will increase. So during inspiration, the transmural pressure for the external pulmonary vessel will increase. What does that mean? That means that during inspiration, because my transmural pressure increases, my vessels are going to be more dilated. Okay. What's going to happen during expiration? Obviously, your chest wall, well, it becomes smaller, okay? It compresses, so the volume decreases and the pressure increases. And during expiration, the pleural pressure is going to increase. What will happen to transmural pressure? It's going to decrease, and the vessels are going to become narrow. Okay. What did we talk about? The difference in pressure, right? The pressure gradient. What would that do to flow? So this is my pressure within the vessel, right? Because in inspiration, my external pressure is decreasing, my internal pressure or the transmural pressure increases. Okay, because of which the vessels are going to become dilated. Because they're going to become more dilated, there's going to be more flow to these extrapulmonary vessels during expiration. And during expiration is going to be the opposite. Okay. Now, what about the bronchial vessels? The bronchial vessels are also similar. Now, what are the bronchial vessels, right? So we have the pulmonary circulation, which is the pulmonary artery, the pulmonary vein, and this is responsible for gas exchange. Then we have a separate circulation for the lung itself, so that it can supply the lung tissue, okay? And these are the bronchial vessels. These sit on the bronchi, okay, around the bronchi, and they supply it, and so on. Because they're surrounding the bronchi, what is surrounding them is the pleura, right? I mean, the whole thing is surrounded by the pleura. So again, the same scenario, right? So during inspiration, the pleural pressure is going to decrease. And because the pleural pressure is going to decrease during inspiration, the transmural pressure is going to increase, okay? And because of that, the vessels are going to become more dilated, and that would increase the flow of blood to these vessels during inspiration. And during expiration, it will be the opposite. Okay, so bronchial vessels and extrapulmonary vessels, they are similar in the external pressure. Now, finally, let's talk about the alveolar capillaries. Now, the alveolar capillaries are the ones which we are interested in, right? There's a pulmonary artery, which will give rise to these, capillaries, and then the pulmonary vein is going to draw the blood from them. Okay, you surround the alveoli. They sit on the wall of the alveoli. Now, what happens to the alveoli during inspiration? The alveoli are going to expand, okay? Because they're filling with air. Because they expand and these vessels are sitting on the wall of the alveoli, these vessels are going to become compressed. I hope that's clear. They're going to become compressed, and the external pressure is going to increase. The external pressure is going to increase. So what's going to happen to transmural pressure? It's obviously going to decrease, right? So during inspiration here, the vessels are going to narrow. They are going to narrow, okay? And because they narrow, the blood flow to these capillaries during inspiration would decrease. The blood flow would decrease. Okay. And during expiration, the blood flow would increase. Why? Because the alveoli will become, well, they're pushing all the air out, so they're becoming narrow, and that would stretch on the vessels, and the vessels would expand. And that would increase the blood flow to them. Okay. Again, this is just what we've talked about. Extrapulmonary vessels, they would dilate during expiration, constrict during expiration. Bronchial is the same, alveolar, they constrict during expiration, dilate during expiration. Okay, now why is important? Because we said that, for example, whenever the vessels would become dilated, what is going to happen to the resistance? The resistance is going to drop. Okay, this is basic physics. Okay, whenever something dilates, the resistance inside of it is going to decrease. And when something constricts, the resistance inside of it is going to increase. Okay, so if we look at these, for example, the extrapulmonary vessels, because they're dilating during expiration, their resistance inside of them is decreasing during expiration. For the bronchial vessels, they're decreasing during expiration. For the capillaries, they're narrowing, because of which the resistance would increase. Okay. But here is the problem, or here is the ambiguity, the problem here. So during expiration, the alveolar resistance would decrease because they become dilated, and the extra-alveolar, such as the vena cavas and the bronchial vessels, their resistance would increase. But during expiration, it's the opposite. One increases and the other decreases. So what is happening here? This is like a tug of war, right? One is increasing the resistance, other is decreasing it. What's going to be the result? Well, what we find is that the total resistance, right, which is being contributed by the alveolar, which is being contributed by the extra-alveolar vessels, alveolar vessels and extra-alveolar vessels, it's lowest at something called as FRC. What is FRC? Which you should know by now, hopefully. FRC is functional residual capacity, right? Is the volume of air in the lungs after you normally expire, right? During this time, the resistance, both of them combined, is going to be the lowest, okay? And then from here, if we inspire, like we normally do, the alveolar resistance will increase, and that would increase the total resistance. But the extra-alveolar would decrease, as you're seeing here. And when we expire from this point, the alveolar resistance would decrease and the extra-alveolar resistance would increase. So the maximum, you could say, stability point, or the point of lowest resistance, would be the FRC. I hope that's clear. Now I have a question. Let's say that the FRC in an individual changes. Now, what will be an example? Obviously, you're not going to take these diseases in detail. Wait for 30 years for that, inshallah. But one of the diseases that causes an increase in FRC is COPD, chronic obstructive pulmonary disease. Now, because it causes an increase in FRC, the FRC is not going to be here. Its FRC is going to be, let's say, here or whatever. So it's going to be now at a higher resistance, than normal. Okay, what would that mean for the pressure of the vessel? It will be high as well, right? The pressure will increase. Okay. What happens, for example, systemic circulation, right? What happens when the blood pressure is too high or for too long? What do we call it? We call it hypertension, right? We call it hypertension. The same idea applies here. Because the pressure is high in the pulmonary circulation for a long period of time, we will call it pulmonary hypertension, right? Pulmonary hypertension. Okay. What happens to the heart, to the left ventricle of the heart, as a result of chronic hypertension, right? Took this in cardio, hopefully. Increase in pressure would mean increase in afterload. Increase in afterload means the left ventricle would have to work harder, it will become more muscular, and it will undergo hypertrophy, right? Left ventricle will undergo hypertrophy. Would this also apply here? Yes, it would. The hypertension, the pulmonary hypertension, would mean that the right ventricle, not the left ventricle, the right ventricle has to work against a higher pressure. It has a higher afterload, right? And that would result in right ventricular hypertrophy. Right ventricular hypertrophy. Okay. What happens when hypertrophy, for example, let's say of the left side of the heart, when it persists for a long period of time? Now, initially, it will compensate for the hypertension. It will compensate for the increased afterload. But over time, the heart would start failing. And that would result in left-sided heart failure. Would that be any different here? No. Sustained pulmonary hypertension would then result in right-sided heart failure. And we call this cor pulmonale, okay? You probably don't have to know the cor pulmonale term, but it's always helpful to relate what you're studying to pathology, because that is what we study. We study in medicine to treat diseases, right? So that is called as cor pulmonale, which is heart failure, which occurs as a result of pathology in the lung. So I hope this is clear so far. Okay. Now this is easy to understand. One of the things that can increase cardiac output is exercise, right? Which a lot of us don't do. Exercise will increase cardiac output. Okay, what will happen as a result of increased cardiac output? The hydrostatic pressure within the vessel is going to increase, right? Including the pulmonary vessel. Because the hydrostatic pressure within the pulmonary vessel is going to increase, okay? The pressure is going to increase. What would that result in? The resistance, right? It would result in actually the dilation of the vessels, because it would increase, the vessels will become more dilated. Because they become more dilated, the resistance would decrease, okay? And this is what's being shown here. So when you increase the cardiac output, so for example, from normal here, and you increase the cardiac output, you are going to decrease the pulmonary vascular resistance, okay? And what we talked about is distension. So these are the normal vessels, and these would expand, and as they expand because of increased hydrostatic pressure, the resistance is going to drop, okay? And this is called distension, and that is what drops the vascular resistance. Another thing which happens during exercise is normally in your lungs, there are some vessels, there are some arteries and whatnot. They are not completely open, or they're closed at rest. But exercise, because it increases the hydrostatic pressure and the flow of blood and so on, it will cause them to open. So for example, you can see, for example, these vessels are closed at rest, and here they become open. And this is known as recruitment. And what happens? The vessels are closed, now you open them, you distended them, you drop the resistance again. So these two mechanisms would help to drop the vascular resistance as a result of increased cardiac output. A common cause of this is exercise. And obviously, if you decrease the cardiac output, you're going to decrease the pressure. The vessels are going to become more narrowed, and the resistance would increase. And again, this is easy to understand, hopefully. Now, this is mentioned in the lecture, so I thought, why not explain it? So this is Swan-Ganz catheter. Now, what is Swan-Ganz catheter? This is a device which is used to measure the pressure in different parts of the heart, right? In different chambers of the heart. More importantly, being the left atrium. Okay, so what do? We insert a catheter. The catheter has a balloon near its tip, and near the tip, there is like a pressure measuring machine, okay, which measures the pressure. I should remove the ink so that clear. So yeah, so it's a pressure measuring machine on the tip of it, right? So whenever you put this machine, the tip is going to record the pressure of that area. So first of all, we put it in the venous circulation, and then it comes into the right atrium, and it records the pressure in the right atrium. As you can see, it's very low pressure. We know that. It goes into the right ventricle, and that would show the pressure in the right ventricle. You know that it's going to be higher than the right atrium. And then it goes into the pulmonary artery. The pulmonary artery pressure is obviously high. It measures that. And then it shows this wedge pressure, right? What does wedge pressure reflect? How do we arrive at this? So essentially, once you put it in a pulmonary artery, you're going to inflate the balloon. Once you put it, you're going to inflate the balloon. And once you inflate the balloon, the pressure which is recorded after that will be the wedge pressure. And that is the pressure in the left atrium. But why? How does that make sense, right? We just inflated the balloon and now we have the left atrium pressure? Well, it's rather easy to understand. Once you inflate the balloon, you're going to occlude the blood supply, right? This is the artery. So the blood is going to, not flow, right, beyond this point. And here the column of blood is going to sit there, and it's not going to move. Because it's not going to move, it's going to equilibrate with the pressure in the left atrium, okay? It's going to equilibrate with the pressure in the left atrium. The pressure which we observe after the inflation of the balloon would be the wedge pressure, or the pressure in the left atrium. Oh, that's clear. Okay, now time for question, right? So I can read it out. So a 65-year-old man with a long history of chronic obstructive pulmonary disease presents with progressive shortness of breath, chest discomfort, lower limb swelling. On examination, there is jugular venous distension, hepatomegaly, and bilateral ankle edema. Echocardiograph will shows a right-sided pulmonary hypertension. We talked about this again, and evidence of right-sided heart failure, or pulmonary. We talked about this as well. Now, which of the following changes in lung volume is most likely responsible for the increased pulmonary vascular resistance leading to this patient condition? So what do you guys think? Okay, I'll give a few seconds if anybody has an answer to this. That's right. It is B, right? The right answer is B. Again, we talked about this, right? The patient has, pulmonary hypertension and right-sided heart failure. Okay. The thing that causes the pulmonary hypertension that could result in pulmonary hypertension is an increase in FRC, right? This is a case-based question, which can be given to you in the exam. Most of the time for first year, you can just get the answer by reading last two sentences. But sometimes you might have to focus on the case. So focus on what they're asking. Don't be thrown off by, like for example, jugular venous distension. What is this? I never took this, just it's fine, right? Focus on what they're asking about. So yeah, increase lung volume, increase FRC, that would cause pulmonary hypertension, that would cause right-sided heart failure. So I think that's clear. So does anybody have any questions regarding the part that we have finished so far?
Yes. Why does increasing FRC cause the hypertension?
Okay, perfect. So we can go back to this slide, right? So essentially, we talked about it, right? So we have essentially tug of war, we have two sides, right? So alveolar resistance is increasing during inspiration, and extra-alveolar resistance is increasing during expiration. So the resistance are increasing in both sides, during inspiration and during expiration, okay? So that is the total resistance. What we find is that the total resistance, right, combination of all of these is the lowest as FRC. Agreed? I hope that's clear, right? So it's lowest as FRC. Now, in certain conditions, let's say in COPD and whatnot, the FRC is not going to be at this point. It's going to be at a different point, right? It's going to be increased. Because it increases and it's at a higher resistance, okay? It is a higher resistance. Now, what do we mean by a higher resistance? The higher resistance would reflect as an increased pressure of the circulation, right? If something has a higher resistance, that means that the blood is having a hard time flowing through it, and that would increase the pressure. And that pressure increase over chronic periods of time can result in hypertension, which we call here is pulmonary hypertension, right? Similar to, for example, your systemic circulation. When you have high resistance and you have high pressure for long periods of time, we call it hypertension, right? And that would result in pulmonary hypertension. And that pulmonary hypertension, as we mentioned, similar to systemic circulation, would cause an increased load on the right side of the heart. And that will cause hypertrophy of the right side of the heart, eventually resulting in heart failure. So does that clear your question, or is that not clear yet? Okay, great. Right. Okay. Now we can move on to the next part of the same lecture. I'm not going on to another lecture yet, but the next part of the same lecture, which is hypoxia-induced vasoconstriction. Okay. So let's say we have these alveoli, right? I want you to focus on this part. So let's say we have this alveoli, these two alveoli, and this is the blood supply to the alveoli, and these are the capillaries. Let's say, due to certain reasons, I don't know what, right? Obstruction of this bronchi and whatnot, the air supply to the alveoli is restricted. So the alveoli is not getting ventilated, which is just a fancy term for it's not getting, air properly. Because it's not getting ventilated properly, it's not going to receive the same amount of oxygen, right? So the partial pressure of oxygen, which we're going to talk about, but the partial pressure of oxygen is going to be lower. And we call this hypoxia, right? There's lower oxygen content in the alveoli. Because there's lower oxygen content in the alveolar capillaries will undergo a reflexive mechanism, right? And that is, they will undergo constriction. That is, they will undergo vasoconstriction, okay? And this is known as regional hypoxia or regional hypoxic vasoconstriction. Now, the question is this a helpful mechanism? Is this a good mechanism to have a vessel narrowed due to airway obstruction? The answer is yes, it is. Why? Because this region is not getting proper ventilation. And if it's not getting proper ventilation and we supply it with the same amount of blood, we are wasting that blood, right? The blood is going to a place where there is, not sufficient amount of air coming in, not sufficient amount of oxygen coming in. And this vasoconstriction would ensure that the blood flow is diverted away from this region to a normoxic region or to a region which is normally ventilated. Now, you might ask, okay, why all this? Why divert blood supply? Why not, have vasodilation here and here? Well, the reason for that is because we don't have unlimited blood supply, right? When we give to one region, we take from another region. So we need to make sure that the region which is normally ventilated is receiving the proper amount of blood supply, and the region which is not ventilated is not receiving, it's not receiving excessive blood supply. So that is, I hope that's clear. And that's regional hypoxia, which is a very, very good mechanism. Now, there's another one, which is generalized hypoxia. So when could generalized hypoxia result? So this is an airway obstruction in one bronchi, in one airway, or one specific part. But what if the entirety of your lung is suffering from hypoxia? And an example of this is when you go to a higher altitude. When you go to a higher altitude, the pressure in that higher region would drop. Why? The pressure of oxygen, the pressure of any gas would drop. Why is that? Because of basic physics, right? Pressure is rho, which is density times gravitational force times h. H is the depth. Okay. The lower you go, in terms of atmospheric level, the lower you go, the higher the pressure. If you go high, the pressure would drop, including the pressure of oxygen, because of which you're going to have generalized hypoxia. When you have generalized hypoxia, you're also going to have generalized vasoconstriction. Okay, now, in this situation, is this a good mechanism? Not really, no, because although it's good to have vasoconstriction in specific areas, here it's all over the place. So the blood is not getting ventilated, right? Because it's not getting ventilated, it results in hypoxemia. That is, the blood will not be oxygenated to adequate levels. We're going to talk about hypoxemia, inshallah. But that's the idea, right? The blood is not getting oxygenated. So that's a problem. Generalized hypoxia is not a good mechanism. Okay. What else would generalized hypoxia result in? Obviously, we said it results in generalized vasoconstriction. What would that do to resistance? That would cause an increase in resistance, right? And that will be translated to an increased pressure within these vessels, right? And the increased hydrostatic pressure will result in, well, we know one thing that it results in, and I'm going to ask you this, but one of the things that it would result in is high altitude pulmonary edema. Why? Because the increase in pressure, when we say increase in pressure, we mean hydrostatic pressure. We mean hydrostatic pressure. Now, you may have taken this, I think you have taken this in cardio, which is factors which lead to edema. One other factor which leads to edema is increased hydrostatic pressure. That is, the blood which is coming in is hitting the walls really strongly, as a result of which it can escape more easily and resulting in edema, right? Which is just collection of, for example, blood or fluid in the interstitial space outside of the vasculature, excessive collection, right? So it's high altitude because high altitude results in generalized hypoxia and pulmonary edema. Okay. The second thing, obviously, which it would result in was what we talked about with changes in FRC, right? We said the change in FRC would result in increased resistance, and the resistance would increase pressure. That would result in pulmonary hypertension. That would result in right ventricular hypertrophy and then heart failure. The same applies here because it's the same principle applies here, right? One other thing in medicine that you should know from this point onwards is that it's very important to have strong fundamentals. And part of having strong fundamentals is having strong principles, right? You understand the principles of, for example, cardiology. Like this is a principle, right? You understood the principle from that point of FRC, hopefully. And now, even without me explaining it, you already know what it can result in. And this is the beauty of understanding principles. Anyway, so that's what happens in generalized hypoxia. Now, what is the mechanism which results in this hypoxia? Well, what it's thought to do is that hypoxia would cause inhibition of potassium channels, right? So we know that potassium channels, normally when they open up, they will result in efflux of potassium, and that would result in hyperpolarization, normally. When you block this, you block the hyperpolarization from happening, the cells the membrane would become depolarized. Because they become depolarized, this will cause the opening of calcium channels, right? Which are waiting for this depolarization to happen or oxygen potential to occur. Opening of calcium channels, right? Again, all this is happening within the smooth muscles, right, which surround the blood vessels. Okay, so opening of calcium channels, and that will cause smooth muscle contraction, right? More calcium comes in, it's used for the myosin, actin contraction, cycling, and that would result in contraction, and that would result in vasoconstriction. Another mechanism that results in this, I don't know if you should know this, but it's mentioned in Dr. Shams's notes, is hypoxia would also cause the release of endothelin or endothelin 1. Okay, and this is also a vasoconstrictor. Okay, this will also cause vasoconstriction. That's another one. Now, in cardio, you would have taken that hypoxia does not result in vasoconstriction. It results in vasodilation. And what mediates that vasodilation? Again, if hypoxia here is closing the potassium channel, it opens the potassium channel in the skeletal muscles, in your systemic circulation, right? Example, skeletal muscle, but other examples also are there that would open the potassium channel, hyperpolarize the membrane, smooth muscle relaxation and vasodilation. Also, it causes the release of nitric oxide, which would also help in vasodilation as well. Okay, so that's for this slide. Now, the idea, we discussed it, right? We discussed why we need to have this vasoconstriction, but the general principle, we're gonna talk more about this. Well, not me, because I'm not gonna cover the ventilation perfusion mismatch lecture. But the main idea is that between the ventilation, which is the air coming in, and the perfusion, we gotta match the ventilation to perfusion. We cannot have an X amount of ventilation receiving excess perfusion. For example, the ventilation is decreased or the perfusion is normal, because that perfusion would be wasted. Perfusion, we mean the blood supply to it. That perfusion would be wasted. Or the opposite is also true, right? We cannot have a well-ventilated area with low perfusion. We need to ventilate it. So that's the idea, right? We got to match the ventilation to perfusion. We talked about one mechanism, which is the hypoxia, which causes vasoconstriction, and this helps to match the ventilation to perfusion by, for example, decreasing the perfusion. The other is hypocapnia. You should have taken this another earlier pulmonary lecture, but just to recap, hypocapnia, what do we mean by hypocapnia? Which means hypo means less carbon dioxide, right? When can we have less carbon dioxide? When we are really well ventilated. An example of this is when you're breathing really fast. When you're breathing really fast, you're bringing a lot of oxygen and you're blowing off carbon dioxide like crazy. And that results in hypocapnia. When hypocapnia results, your bronchi, your bronchial airways would respond by bronchoconstriction, by constricting, by narrowing. Why? Because hypocapnia is essentially telling us there's too much ventilation going on, we got to stop it. And bronchoconstriction does exactly that. It decreases the ventilation, right? Because CO2, it normally has a bronchodilator effect, right? When you have a lot of CO2 in hypercapnia, it would result in dilation. And when you have less, it would result in bronchoconstriction. I hope that's clear. Now, these are the two mechanisms which helps in this. Let's use these mechanisms to understand this. Let's say we have, two alveolar regions, right? So the first alveolar region has high ventilation, as you can see by this huge arrow. It has high ventilation, but it has low perfusion, okay? So what's gonna happen to this region over time? Because it's a high ventilation, low perfusion, a lot of oxygen is coming in, so the region will become hyperoxic. But because there's less blood supply, the blood is not dumping carbon dioxide, and the region would become hypocapnic, okay? Low CO2 in the alveoli, okay? Now, what's going to happen as a result of hypocapnia? We said that hypocapnia will induce bronchoconstriction. Bronchoconstriction would decrease the ventilation, it will lower the ventilation and match it to the perfusion. The goal is achieved, okay? The second reason is, let's say, for some reason, it is poorly ventilated, so the ventilation is low and the perfusion is quite high, okay? What's going to happen? Well, a lot of blood is coming in, but it's not being able to blow off the carbon dioxide. Why? Because it's not very well ventilated. So this region is going to become hypercapnic, and because it's not being ventilated well, less air is coming in, it becomes hypoxic. Okay. Which mechanism would help to match these two values? Vasoconstriction, right? We talked about this. Vasoconstriction would decrease the perfusion. So, low ventilation is matched with low perfusion. I hope that is clear. Now, we will start discussing the, oh man, I'm getting thirsty. Okay, we'll start discussing the ventilation distribution across the different parts of the lung. Obviously, I'm going to talk about it here, but this is, I believe, more extensively covered in your ventilation perfusion mismatch lecture again. But Dr. Shams mentioned it here, so I'll attempt to, explain you guys this. Okay. So the lungs, the alveoli in the lungs can be divided into three regions, right? So we have the apex, the middle, okay, and the base. Okay, so zone 1, zone 2, zone 3. Okay. So the perfusion in each one of these zones is not the same, okay? It's different. So some regions have a higher perfusion as compared to others, okay? Now, why is that? And why is that, and what does that result in? Okay. So again, the concept of pressure comes back, right? So we said that the pressure would increase with an increase in height or an increase in depth. An increase in depth, right? The lower you are, the higher the pressure. The same applies to fluids. So the lower the fluids are, the higher will be the pressure. So the hydrostatic pressure will be the highest, which is of the blood supply. It will be the highest within the blood itself. The hydrostatic pressure is going to be the highest at the base, right? The hydrostatic pressure is going to be highest at the base. And it's going to decrease as we rise up, right? Because we are going higher and higher, so the pressure would become lower and lower. Because the hydrostatic pressure is the highest, that means that the perfusion to that region is also going to be the highest. Very simple, right? Very simple. The vessels are going to be really dilated, and that's going to have a lot of flow coming in. And that would mean that the perfusion, which is, denoted by Q, is going to be the highest at the base. And at the middle is going to be a bit high, and at the apex is going to be the lowest, okay? So for perfusion, when we go from the apex to the base, okay, a horrible arrow here. But anyways, when you go from apex to the base, the perfusion is going to increase, with the highest being at the base. Okay, that as far as ventilation is concerned. Now, I'll talk about perfusion in a bit, but let's talk about something called alveolar pressure. Now, what is alveolar pressure? It's the pressure which is generated within the alveoli, right? Within the alveoli, something like this. Okay, this pressure is also not equally distributed. Why? Well, let's try and understand this again. You see, the lower alveoli, it's not the same as, or the alveolar pressure within the lower alveoli in the base is not going to be the same as the pressure in the alveoli in the apex. Why? You see, the lower alveoli, they're sitting at the base, and they are sitting under the weight of all of the lung tissue, lung parenchyma, which is above it. So therefore, these will be more narrowed or more compressed at rest or at FRT as compared to the alveoli in the upper region. So because they're more narrowed, the alveolar pressure within it is going to be low, right? It doesn't have much air within it, so the pressure is going to be low as compared to the middle alveoli, which are going to be more freer because they are under lesser amount of weight, right? The gravitational force or the gravitational weight, as opposed to the apex, which are going to be even more freer, even more opened up, right? And they're going to have the highest alveolar pressure, okay? So the alveolar pressure, which is PA, as we go from apex to the base, it would decrease, okay? So the alveolar pressure decreases as we go from apex to base, and the perfusion would increase as we go from apex to base, okay? Now, what would that result in? It results in something like this, right? Because at the apex, we said that the alveolar pressure is going to be the highest, and the perfusion is going to be the lowest. Because the perfusion is the lowest, the pressure, which is the pulmonary artery pressure and the pulmonary venous pressure, is going to be lower than the alveolar pressure, right? And at the middle is going to be, well, the pulmonary artery pressure is going to be more than the alveolar, which is going to be more than the pulmonary venous. And at the base, obviously, the pulmonary artery is going to be the highest because the perfusion is the highest. And this is actually pulmonary vein, sorry. And then after that would be the alveoli. Now, I'm not supposed to touch on ventilation, but I'm going to do it because it's linked with this, right? Now, based on this, I'll say this. The ventilation is going to be the highest at the base. Why? Right? Let's use the principle which we discussed in alveolar pressure. At the base, we said that the alveoli are going to be relatively more narrow, right? Relatively more narrow, as opposed to the middle, which are going to be more open, and then apex are going to be the most open. Because these are the most narrowed, yeah? I just drew a mushroom, but because these are the most narrow, when air comes in, it has more capacity to expand, okay? Then the middle, and then the apex. The apex is already quite expanded, so they're not going to expand as much when air is going to come in. What does that mean? That means that the ventilation as well is going to be the highest at the base. And as we go towards the apex, the ventilation is going to decrease, right? So both ventilation and perfusion is going to be the highest at the base, and it's going to decrease in the apex, right? Don't tell anyone I taught you this. This is important, okay? You're going to take this in ventilation perfusion mismatch. Right? Now, for anatomical shunts, okay? So anatomical shunts, well, before that, let's discuss something, right? So generally, when the blood supply, so again, this is the the right side of the heart, the right ventricle, the right atrium, right? The right ventricle is pushing this blood into the pulmonary artery and it's going through the, for example, the lungs, okay, or the alveoli, and it's going to return it back into the left atrium of the heart. It's going to return blood which is oxygenated, right? And the partial pressure of oxygen, which we're going to talk about, which is just the pressure of oxygen, is going to be 100 millimeters of mercury, right? So before it enters, it's about 40 millimeters of mercury. 40 millimeters of mercury, and after it leaves the alveoli, it's going to be about 100 millimeters of mercury. Okay. Now, once it goes back to the heart, it goes back to the left ventricle, and it goes into your systemic circulation, you expect the pressure to be 100 millimeters of mercury, right? Because it's oxygenated and no exchange should have happened by this point. So if I, for example, take a pressure, or catheter, whatever, I measure it in my aorta or in my systemic circulation, it's the pressure for oxygen. Okay, I'm not talking blood pressure. Pressure for oxygen should be 100 millimeters of mercury, right? But that's not the case. When we measure it, we're not going to see 100. We're going to see about 90 or 92 or 93. Why is that, right? Which means that there is something going on, right? We are diluting this blood, or we are mixing it with some deoxygenated blood somewhere, somehow. And the answer to that question is, how is that happening? Is through the anatomical, it's through the anatomical shunt, okay? So we have these shunts, obviously. I don't know if you covered this in other lectures. Shunts can be pathological or they can be physiological. Physiological means they are normally present, okay? So these are the shunts. These are two examples of this. The first one is the patient veins, very fancy name, or vena cordis minima, even more of a fancy name. So these veins are veins which drain the coronary circulation, right? They would drain the coronary circulation. Obviously, venous drainage is going to end up in the right side of the heart, in the right atrium. But some of these veins, they drain into the left ventricle directly, right? Because they drain into the left ventricle and it's deoxygenated blood, it's going to lower the partial pressure of oxygen. The other ones are the bronchial veins. We talked about the bronchial blood supply, which is supposed to supply the lungs with nutrition. And they're going to come with bronchial artery, and they're going to leave by bronchial vein. And most of that bronchial vein will go and drain into the right side of the heart. Okay, but some of those will hijack the pulmonary vein. Okay, some of those will hijack the pulmonary vein. Obviously, pulmonary vein carries oxygenated blood. And because the bronchial veins are going to carry deoxygenated blood, they're going to mix with the oxygenated blood and lower the partial pressure of oxygen. Okay, so these are two examples of anatomical shunts. All right. Now, okay, I'm sorry, this is a mistake. These are not physiologic shunts. These are pathologic or abnormal. Okay, so these are some pathologic shunts like patent foramen ovale, which you should have covered in other places. You're not supposed to cover this in Palmo, but anyways, patent foramen ovale, obviously between the two atria, embryologically speaking, we have a connection which goes away once you're born, but in some people it can persist and it can mix the deoxygenated blood with the oxygenated blood. Patent ductus arteriosus. Again, this is a embryological connection between the aorta and the pulmonary artery, as you can see here. Present during embryologically speaking, it's present in that period of life, but once you're born, no, it's not present anymore. It closes, but it can remain patent in some patients, and that can mix the deoxygenated blood with the oxygenated blood. Ventroseptal defect, it's a, well, as the name suggests, it's a defect in the ventricular septum, causes the mixing of blood between the right side of the heart and the left side of the heart, or the ventricle. Left ventricle, again, pathologic shunt. Pulmonary AV fistula, it's just a abnormal connection in certain people, because abnormal connection between the pulmonary artery and the pulmonary vein, and obviously this would mix the deoxygenated blood with the oxygenated blood, and that would cause a decrease in partial pressure of oxygen. Okay. Now, question time. Let me drink some water and then I'll read it. Okay. A 60-year-old man with a long history of COPD presents with progressive shortness of breath and fatigue. On examination, he has cyanosis, wheezing, and bilateral ankle edema. Arterial blood gas shows hypoxemia and hypercapnia. Chest X-ray reveals hyperinflated lungs with flattened diaphragm. Which of the following mechanism correctly reflects the physiological process of VQ matching in the lungs? Okay, what do you guys think? Let's see. Oh man. All right, the correct answer is A. Okay. Why is D not the right answer? Okay. So hypoxia will induce vasoconstriction and hypercapnia will induce bronchodilation. Nothing wrong with that, right? But the one which covers for the mismatch would be the hypocapnia. Although, hypercapnia can do it, okay? But hypocapnia is more so responsible where you have excessive ventilation, okay? Also, when you have hypercapnic induced bronchodilation, this is helpful if you, let's say, if the obstruction is not excessive. If it's excessive, then this won't be as helpful as the vasoconstriction itself. So these are the mechanisms that we have covered. This obviously, for example, if this comes in an exam, you have every right to appeal this question. But the reason why I put it is because this is covered in your lecture, right? This is what we covered in the lecture. This can also be the right answer. But whatever is covered in the lecture, go for that one. Even if, let's say, you have another options, let's say, which makes sense. But if one of them is mentioned in the lecture, sometimes that's the only explanation, right? Even though D can be correct, I absolutely agree with that, right? But A is mentioned in your lecture and we mentioned it. That is why. And this is kind of like a lesson in exams. Sometimes you might pick an answer which makes every perfect sense. But the only reason why they say it's wrong is because it's not mentioned in the lecture. So, that's why you should pick A, although both of them would be correct. Okay, I hope that's clear. Yeah, game's the game. Okay. So now we can start with the blood gas. Okay, so now we can start with lecture number 25, which is the blood gas transport. So in blood gas transport, first of all, we're going to talk about the transport of oxygen. Okay, so there are two ways to transport oxygen in our blood. One of them is physically dissolved in plasma, okay, and the other is going to be hemoglobin. We're going to talk about it. The physically dissolved essentially means that we have this gas and we're dissolving in it plasma. That's it, okay? And this is governed by physics, okay? It's governed by something called Henry's law. And what does the Henry's law state? First, I'm going to say what it is and I'm going to explain it. Henry's law states that the concentration of a gas in plasma is equal to alpha, which is the solubility coefficient for that gas, times the partial pressure of that gas, okay? Partial pressure of oxygen. Okay, because we're talking about oxygen. So what it's essentially saying is, if we are given the partial pressure of oxygen, don't worry, I'm going to talk about this, we can acquire the concentration of oxygen through that. Okay. Now, what do we mean by partial pressure of oxygen? Okay. So when we talk about air, the atmospheric pressure is about 760 millimeters of mercury. Okay. Is oxygen the only thing that we find in air? No, right? We find other gases, but oxygen is only 1%. And because it's 21%, it's not going to exert all of that pressure. It's going to exert a partial amount of that pressure, right? And that partial pressure of oxygen is usually 150 millimeters of mercury. That is what we refer to as the partial pressure, which is the pressure which is being exerted by a component of the total mixture of gas, right? That is the partial pressure. Now, how do we understand this in relation to, for example, blood flow? Okay, so let's take this example. Let's say this is a beaker, and within this beaker, this is fluid, okay, here, and above that, we have gas, okay? And oxygen is present in the fluid and is present in this layer, in the layer of gas above it as well. Okay. What this equation says is that if I increase the amount of oxygen in this layer of gas above it, I will also increase the amount of oxygen which is present in the plasma. It's simple as that, okay? Why do we need to look at it that way? Why can't we just, for example, dump a lot of oxygen in the liquid itself? The reason for that is because when we take in oxygen, the way we acquire oxygen is not through taking supplements or through food. No, we take it through air. Okay, when you are taking in air, that oxygen, which is dissolved in air particles, is going to come and is going to dissolve in your plasma. And that is what we mean by physically dissolved oxygen. When you have a higher amount of oxygen in the air, which is the higher pressure of oxygen in the air, you're going to increase the amount of oxygen which is dissolved in the plasma. Okay, and this is Henry's law. This is essentially what Henry's law states. Okay, now let's go through the transport of oxygen is acquired. Okay, so this is, let's say, the alveoli. Okay, and this is the blood as it's coming in. Okay, so let's say this is the pulmonary artery, and this is the pulmonary vein. The pulmonary artery, as it's coming in, it carries deoxygenated blood. Because it carries deoxygenated blood, it's going to have a lower partial pressure of oxygen. Let's say it's 40 millimeters of mercury. Okay, and the pressure in the alveoli of oxygen is 100 millimeters of mercury. Agree? Okay. When this is going to come here, okay, there's going to be a difference in the partial pressure of oxygen. 100 in the alveoli, 40 in the blood. Is there going to be diffusion of oxygen or transport of oxygen? Yes or no? Yes. Okay. The diffusion of oxygen here would depend on the gradient or the difference in the partial pressure of oxygen. And the oxygen particles will move down, not concentration, the pressure gradient. Because it's 100 here and it's 40 here, and it's higher in the alveoli, it's going to leave the alveoli and it's going to move into the blood. All right. When it moves into the blood, okay, it's going to increase the partial pressure within the blood. So let's say, for example, it equilibrates, right? So it equilibrates and it becomes from 40, it becomes 100. And it stays 100 here because, you have air coming in, that's fine. Once it becomes 100 millimeters of mercury, it's not just the oxygen which is present, in gaseous form. It would also mean that it will increase the concentration of dissolved oxygen, okay? According to Henry's law, right? So we're increasing this from 40 to 100. Because we're increasing that, we will also increase the concentration of oxygen, which is dissolved in the plasma. All right. Now, once that happens, you have 100 millimeters of mercury, and simply, we are just going to leave the pulmonary circulation, and it's going to circulate through the rest of the body, right? But now, we said that there are two transport mechanisms of oxygen. One of them is physically dissolved, which we're talking about, and the other one is hemoglobin, right? Being transmitted by hemoglobin. I'll tell you this. Despite all the system appearing very fine and dandy, this is ineffective. It will not supply us with efficient amount of oxygen, the one which we need. Why? Because let's say we have 100 millimeters of mercury of oxygen, partial pressure of oxygen in the venous blood, and that's normal. Okay, this is translated to how much of concentration of oxygen? It's about 3 to 5 milliliters. 3 to 5 milliliters, okay? And if cardiac output is about 5 liters, we're going to multiply by, let's say, 3. We're going to have about 15 milliliters of oxygen circulating per minute through our body. How much do our tissue need? How much do our tissue need in terms of the concentration of oxygen? For the tissues to function normally at rest, it requires 300 milliliters of oxygen. And we're only supplying 15 through this physical dissolve method. Even though the partial pressure is 100, it's fine. We're getting everything, normally. It's only 15 milliliters of oxygen. So we clearly need a better way to transport oxygen. In comes hemoglobin. Hemoglobin binds to oxygen, we're going to talk about it, and carries oxygen to different parts of your body. And this is responsible for over 70% of the oxygen delivery or the oxygen transport. That is being bound to hemoglobin. Right? Now, let's discuss the structure of hemoglobin. Hemoglobin is made up of 2 alpha and 2 beta subunits. And each of these subunits, these are protein globin chains, have heme group. Okay, each one of them has heme group, and each one of these heme group has a central ion atom, which exists in the form of Fe2+. And each Fe2+, or each heme molecule, or each subunit, can only bind to one oxygen molecule. So one oxygen molecule here, one here, one here, one here. So overall, the hemoglobin itself can bind to one hemoglobin molecule can bind to only 4 molecules of oxygen. Don't worry, we have plenty of hemoglobin within the RBCs. But do we have unlimited amounts of hemoglobin? No, right? We have a limited amount of hemoglobin, albeit in a really large amount of capacity. We still have a limited capacity, right? So we have a limited carrying capacity of the hemoglobin for oxygen. That's important to keep in mind. Right, now, the hemoglobin molecule, the structure of hemoglobin, it exhibits a property known as allostatic binding. Okay, what do we mean by allostatic binding? What we mean is that hemoglobin normally has, let's say, an X amount of affinity or low affinity for oxygen. Normally has low affinity for oxygen when it's not bound to any oxygen molecule. But when the first oxygen molecule goes and binds to any one of these subunits, it will cause an increase in affinity for oxygen in the other subunits, in the other alpha and the other 2 beta. Okay? Now, the opposite is also true. When oxygen will dissociate from a fully bound hemoglobin, let's say a hemoglobin which is fully packed with oxygen, okay, fully packed with oxygen, when oxygen leaves from even one of them, the affinity for oxygen would decrease in the other sites, easing dissociation. And this is known as allostatic binding. But the question is, why? Why does the binding of one oxygen increase the affinity of other? Well, the reason for that is because hemoglobin will exist in 2 forms. The first one is the R state, which is just relaxed state. Okay, the other one is the taut state. Okay, or like very, uptight and congested state. So the taut state is the state in which the deoxyhemoglobin, a fancy term for saying the hemoglobin which is not carrying any oxygen, that hemoglobin exists in the T state, and that is going to have low affinity for oxygen. It's going to have a low affinity for oxygen. What about the R state? The R state is a state in which the oxyhemoglobin, a fancy term for referring to a hemoglobin which is packed with oxygen, which is all 4 subunits are carrying oxygen. That is going to exist in relaxed state, and that is going to have really high affinity for oxygen. All right. So the idea is that when you have a deoxyhemoglobin, right? When you have deoxyhemoglobin, and it binds to the first oxygen molecule, that binding of first oxygen molecule will cause the transition of hemoglobin from the T state to the R state. such that it now has a high affinity and it will start to bind to the rest of the oxygen molecule. And the opposite is also true. When the first oxygen detaches from a fully loaded hemoglobin, it will cause the change in conformation, fancy term for the shape of hemoglobin, from the R state to the T state, lowers the affinity so that it will ease the dissociation. Okay? And this is what we mean by allostatic binding. I hope that's clear. Now, this is another thought experiment that it's worthy of going through, I believe. So let's say we have a beaker, okay? Within this beaker, we have, again, liquid. Let's say we have plasma sitting in this beaker, why not, okay? Within this, we have 2 molecules of hemoglobin, all right? Each molecule, we said, has 4 binding sites. So here is going to have 8 binding sites for oxygen. All right. And 8 binding sites for oxygen, which means it can bind to 8 molecules of hemoglobin. Let's say 8 molecules of hemoglobin is about 8 milliliters of oxygen. It's not, sake of simplicity, right? Let's say it's 8 milliliters of oxygen. Okay. So you would assume that because I have hemoglobin, 8 binding sites of hemoglobin, and I have 8 milliliters, and the 8 binding sites can bind to them, all of the oxygen should exist in the form of being bound to hemoglobin, and none of it should be present in the physically dissolved form. Well, that is not correct. You see, only a fraction, let's say here, because we have only 2, but usually you have thousands and a lot. Only a fraction of the hemoglobin, despite the fact that all of it can bind to oxygen, only a fraction of it would exist in the form of oxyhemoglobin. Only a fraction of it. Why? Why not the entire thing? This is because of equilibrium. Equilibrium between the oxyhemoglobin and deoxyhemoglobin, or between the oxygen which is bound to the hemoglobin and the oxygen that is free. And this equilibrium makes sure that there is some amount which is bound to hemoglobin of oxygen, and there's some amount which is free, or which is physically dissolved. Okay, I hope that makes sense, right? So if I want to, let's say, I want more hemoglobin to bind to oxygen, what am I going to do, right? And I cannot increase the amount of hemoglobin. I want more hemoglobin to bind to oxygen. What can I do? I can increase the concentration. How would that affect? Because of chemistry, okay? Equilibrium, right? The concept of equilibrium is if I increase the right side of the equation, any component of the right side of the equation will shift to the left, okay? And the opposite is also true. If I increase the left side of the component, it would shift to the right. So the only way I can increase the amount of oxygen which is bound to hemoglobin is by increasing the concentration of physically dissolved oxygen. And that would increase the amount of oxygen which is bound to hemoglobin. Now, again, can we just take oxygen and dissolve it in the blood, take it through, I don't know, pills or whatever? No, we can't, right? We need to inspire oxygen. So because we need to inspire oxygen, we need to make sure that the partial pressure of oxygen is really high in the blood. If the partial pressure of oxygen is really high in the blood, that will mean that the concentration of oxygen is also going to be high. So if we increase the partial pressure of oxygen, we will increase the concentration. If we increase the concentration, it will shift to the left. If it shifts to the left, it's going to increase the concentration or the amount of hemoglobin which is bound to oxygen. Capish? Okay. This is how we are going to do it. But the opposite is also true. What if I want to say, okay, I don't want hemoglobin to, gatekeep all of the oxygen. Let me have some of the oxygen. No? What do we need to do in that case? We need to take away this oxygen, right? We need to take it away. If we take it away, it will cause a right shift. How do we take it away? Well, the way we are increasing the concentration is by increasing the partial pressure of oxygen. Then how would we decrease the concentration of oxygen? By decreasing the partial pressure of oxygen. If we decrease the partial pressure of oxygen, we are ultimately going to decrease the concentration of oxygen, cause more dissociation of hemoglobin. We're going to come back to this concept because it is important. Okay. All right. So that's the concept for the equilibrium. Now, I want you to understand another thing is that the oxygen, which is bound to hemoglobin, does not contribute to the partial pressure of oxygen. Okay, so when we're talking about 100 millimeters of mercury or 40 millimeters of mercury in plasma and so on, this is only being contributed by the physically dissolved oxygen. If you take away the hemoglobin altogether, it will not change the partial pressure, directly speaking. Okay, it will not change the partial pressure of oxygen in the blood because the partial pressure is dependent on the physically dissolved, right? Or the free oxygen, not the one which is bound to hemoglobin. Right? And the diffusion is, again, we've talked about it, right? It's dependent on the gradient, okay? Difference in the partial pressure of oxygen. All right. Okay, so now we can talk about another, illustration. This is similar to what we discussed before. We had an alveoli, but let's say now we are talking about a tissue site. Okay, so let's say this is a tissue, and within that tissue is going to have, let's say, consumed oxygen from previous cycle, and now the partial pressure is low because the concentration is low. It's 40 millimeters of mercury. All right, and this is the arterial supply to that tissue. Let's say it's muscle. Well, let's say it's muscle. Okay, artery is coming in with 100 millimeters of mercury, and it will leave with the oxygenated blood, obviously. And this is the vein. Okay, it's coming in with 100 millimeters of mercury. All right, it's 100 millimeters of mercury here. Now, the question is there a gradient in or a difference in the partial pressure of oxygen? Absolutely, there is, right? We have a higher pressure inside the vessel and lower pressure inside the tissue. Is there going to be diffusion? Absolutely, there is going to be diffusion, okay? So the physically dissolved oxygen is going to diffuse, okay, into the tissues, okay, and is going to equilibrate, let's say about 60 millimeters of mercury, okay? For the sake of illustration, it equilibrates to about 60 millimeters of mercury. All right, now, has the hemoglobin given away its oxygen yet? The 70% of oxygen which is being transported by the hemoglobin, have they given away their oxygen yet during this diffusion? No, it's only the physically dissolved which is moving into the tissues. That's it. But here comes the crux of this whole process. Because now the partial pressure has dropped, what would that result in, or what would that result in for the concentration of oxygen in the blood? The concentration of oxygen is going to decrease. What would that do to our, cute little equation here? Okay, because the concentration is decreasing, now the hemoglobin is going to dissociate with oxygen and is going to give us more free oxygen. Once the dissociation happens, the oxygen is relieved from the hemoglobin and it moves into the tissues, thereby facilitating the transport of oxygen into the tissues via the hemoglobin. I hope that makes sense, right? Now, for us to have dissociation, we need to have the hemoglobin, which is associated with oxygen. Okay, now where does this binding take place? In the alveoli. Remember we talked about, we had 40 millimeters of mercury coming in and it became 100 millimeters of mercury, remember? When it became 100 millimeters of mercury, what did we do to the oxygen saturation or the concentration of oxygen at that point? We increased the concentration, right? We increased the concentration. Because we increased the concentration, at that point, we would have caused a left shift and formed more oxygenated hemoglobin. And that is where the hemoglobin becomes saturated or becomes oxygenated and carries oxygen. And then it goes to the tissues. And because in the tissues, the partial pressure is going to drop to whatever 60 and whatnot, then it's going to dissociate. So you see how this equilibrium affects the association, dissociation at the right places. So this is a very important concept to understand, right? Wait a second. Great. So again, the lower the partial pressure of oxygen, higher is the oxygen dissociation from hemoglobin. Very clear, right? The lower the pressure, for example, here it was 40. If it was 20, my pressure here will be lower, my concentration will be lower, and I would have more of a right share hormone dissociation. Okay. And now we come to the oxyhemoglobin dissociation curve. This is very, 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 very important concept, which you are going to take into your third year. For example, you're gonna talk about this in third year as well, inshallah. So this is the oxygen dissociation curve, right? So what do we see here? Well, let's orient ourselves. On the x-axis, we see the partial pressure of oxygen. Okay, and this is the partial pressure of oxygen in the blood. Okay, nowhere else, in the blood. On the y-axis, we are going to see the saturation. What do we mean by saturation? We're essentially saying is how much percentage of the hemoglobin is carrying oxygen. That is what we are saying here. Okay, how much percentage of the hemoglobin is carrying oxygen? So when we are talking about, let's say 100%, we are saying 100% of the hemoglobin is filled with oxygen, it's completely loaded with oxygen. At 50%, it's going to be, half of the hemoglobin is carrying it, and so on and so forth, right? Okay. Now, very easy to understand. As we increase the partial pressure, we are going to increase the concentration of oxygen in the blood, and we are going to cause more of a left shift, and we are going to saturate the hemoglobin more and more, and essentially, drive it up to 100%, right? Load it up completely, okay? So that's the idea here, and that's what the curve is showing. The first thing that I want you to notice is the shape of the curve. This is a very characteristic shape. It's known as the sigmoidal, shape or sigmoidal curve. And this is the S-shaped curve. And the reason why it's sigmoidal and it's not, for example, completely linear is because of the property of hemoglobin, and that is the allostatic binding, right? The allostatic binding property of hemoglobin, we already talked about increase in affinity, decrease in affinity, blah, blah. And that is what results in this, sigmoidal curve. The second thing that I want you to focus on is the flatness of the curve as it goes towards the top. Why is it becoming flat? And why is it not increasing? Because it's becoming saturated, right? Remember we talked about the fact that hemoglobin, we have limited amounts of hemoglobin, albeit, lots of hemoglobin, we still have limited amounts. Because of which, okay, there's a limit to which we can load the hemoglobin with oxygen, and that is represented by 100% saturation, okay? Now, this flatness has other implication as well. What is that? I want you to have a look at this. As we go near the top and we increase the saturation, look at the changes in partial pressure, right? The partial pressures, for example, from here until here is changing a lot, okay? For example, it's going from, 75 to 120. But how much is the saturation changing? Not much, right? It's going from, 92% to 100%, okay? Only 8%, but we are changing it, by 40, by 50, the partial pressure. Why is that important? What is one example where you have low partial pressure of oxygen in the atmosphere? We talked about this. This is at high altitude. When you go high altitudes, the partial pressure of oxygen in the atmosphere is going to be lower than normal. Because it's lower than normal, the saturation would, we expect it to drop, right? From the equilibrium equation, you will expect it to drop. But this curve is telling us that it won't drop as much. For example, let's say, the maximum oxygen partial pressure, it goes from 100 to 80. Okay, that's a drastic drop. But the saturation only changes from 100 to 95.8. Okay, so only by 4.2%. We are dropping it by 20 milliliters of mercury, and the saturation is not changing as much, which is very important to maintain the oxygenation, right? You need to have the appropriate saturation to begin with, so that you can unload this oxygen to other tissues. But if you have inappropriate saturation, you cannot supply the tissues with oxygen, okay? So that's the flatness of the curve. The third thing I want you to focus on is the steepness of the curve, right? It's steep around these regions, okay? What does that imply? What implications does that have? That essentially is telling us that, look, when you change the saturation, for example, 40, right? 40 is, oh my God. That's okay, that's horrific. Okay, so when you're changing it by 40, okay, when you drop it to 40, the saturation is about 75%, okay? So let's look at this. So when you go from 75% to 50%, which is a drop in saturation of 25%, okay, my partial pressure is not changing to the same amount, okay? My partial pressure is not changing as much. Because my partial pressure is not changing as much, this allows my peripheral tissues to extract oxygen to decrease the saturation without modifying the partial pressure to the same extent. Okay, so this is important, right? So again, first one is the sigmoidal. All right, the second is the flatness of the curve. The third we talked about was the steepness of the curve, all right, or the lower part of the curve. The fourth thing which I'm going to mention is P50. What is P50? P50 is just the partial pressure at which 50% of my hemoglobin is saturated. 50% of my hemoglobin is saturated. Okay, why P50? Right? Because we use this as a measure. As a measure for what? For affinity. Okay. Once again, what is it? It's just the pressure at which we attain 50% saturation. So let's say here it's 26.8 or 27. Right? Let's say 27 millimeters of mercury, normally speaking. Normally is 27 millimeters of mercury. What if I tell you that the P50 increases? P50 increases. So what does that mean? That means that instead of being 27 millimeters of mercury, I don't know, now it's 37 millimeters of mercury. So now I need a higher pressure to achieve the same saturation. I need a higher pressure to achieve the same saturation. Okay? What does that mean? That means an increase in affinity. Wait, what? How could that mean an increase in affinity? Okay, let's not take the example of P50, but use another example in the context of P50. Okay, so we said that 50% saturation would require 37 millimeters of mercury now. Okay, let's take another example. When you have an increase in affinity, and because P50 is increasing, let's say that at 37 millimeters of mercury, now I'm achieving 50% of saturation, okay? At 37 millimeters of mercury, I'm achieving 50% of saturation. At 27, in the case of, increased P50, my saturation is going to be even lower. You get it? My saturation is going to be even lower. Because my saturation is going to be even lower, that means that I have more of a dissociation. That means I have more of a dissociation. And because I have more of a dissociation, that would mean that I have a decrease in affinity. And that will mean more oxygen can easily go, leave the hemoglobin. And that would cause a decrease in affinity. Okay? And that would result in right shift of the curve. Right? Why does it result in a right shift of the curve? Because the 50% now is not landing on 26.8, it's instead landing on, I don't know, 37, which would be about here. So the curve would look something, okay, the curve would look, why is it doing that? Okay, the curve would look something like this. Okay, it's causing a right shift. Now, what if my P50 decreases? Okay, so if my P50 decreases, that means that I will achieve 50% saturation with a lower pressure. Okay, I will achieve 50% saturation with a lower pressure. That will mean that it's an increase in affinity. Why? Just think about the opposite, right? So let's say instead of 26.8, I'm achieving the saturation at 15. Okay, if I'm achieving the saturation at 15 at 26.8, right, my saturation would be higher than 50 in this case. Because it will be higher than 50, let's say 75%, that means that if I bring it to 26.8 in this situation, only 25% would dissociate, okay? Instead of 50% dissociating. That means that the hemoglobin, it wants to remain attached to the oxygen, doesn't want to let go of it, right? So that is essentially mean that it's an increase in affinity, and that will cause a left shift, okay? That will cause a left shift, right? So again, this is just the overview of what I've talked about. So the right shift would increase the P50, or P50 would increase the right shift. That would decrease the affinity, and that would increase the oxygen dissociation. And the left shift would decrease the P50, will increase the affinity, and decrease the oxygen dissociation. Okay. All right. Now, what are some causes of right shift, right? What are some things which will cause this increase in P50 or decrease in affinity, right? So let's go, through the causes. So first of all, it's increased H plus, increased PCO2, increased temperature, and increased 2,3 bisphosphoglycerate. All of them are just increases. So that's one way of remembering it. Okay, so all of them are just increases. So first of all, is the proton effect on hemoglobin. Okay, so let's talk about the effect of proton on hemoglobin. So these are two states of hemoglobin. This is the R state, right? And this is the T state. Now, which is the state which will more easily bind to oxygen? The R state, right? The R state is the one, which is exhibited by the oxyhemoglobin, and the T state is the one which is exhibited by the deoxyhemoglobin, regular, right? Regularly speaking. Okay, so the R state is the one which is bound to oxygen. Protons can also bind to hemoglobin, but they will not bind to the binding site of the hemoglobin. They'll bind to another site, and this is, let's say, the site, okay? And this Dorito is my proton. And when proton goes and binds to the hemoglobin, it would stabilize the T state. If the hemoglobin is in the R state, it will cause its conversion to T state. Now, what happens in T state? T state is a state of decreased affinity. Because it's a state of decreased affinity, if there is any oxygen which is bound to it, it's going to cause dissociation of that oxygen, right? So the oxygen is going to dissociate from that side. And we know that T state has a decrease in affinity for oxygen, so therefore causing a right shift, right? So basically, binding a proton to the hemoglobin will stabilize the T state, and that would favor dissociation and cause a right shift, right? More the proton, more would be the stabilization of T state, and lower would be the affinity, and more would be the dissociation, right? And this is known as Bohr effect, okay, which is the effect of hemoglobin, the effect of H plus on hemoglobin is essentially known as the Bohr effect, all right? Now, another cause that we talked about was increase in CO2. Okay, an increase in CO2 will cause a decrease in affinity by two mechanisms, right? The first way is that the CO2 will bind to the N-terminus of the alpha and beta subunits, okay? Remember we talked about the structure of hemoglobin. So the structure of hemoglobin is, 2 alpha and 2 beta, okay? Now, the CO2 will not bind to the active binding site. It will bind to the N-terminus site. And once it binds to that site, okay, it will decrease the affinity for oxygen at the binding site. So decrease affinity for oxygen, thereby right shift. Okay, that is the first mechanism. The second mechanism is through obviously H plus. Now, how is CO2 related to H plus? What is the equation, right, that you may have taken, for example, in mole, which correlates CO2 with H plus? That is, an increase in CO2 will increase the H plus. Come on, you know the answer for this. And that is the bicarbonate buffer, right? Bicarbonate buffer system. So we know the bicarbonate buffer system, it has this formula, CO2 plus H2O will give H plus plus bicarbonate, okay? So when you have an increase in CO2, it will cause a right shift, and that will cause an increase in H plus, okay? And that increase in H plus will cause, the Bohr effect, and also decrease the affinity for oxygen, and it will cause dissociation. All right. Now, is this a helpful mechanism? Is CO2, because normally we do have CO2, which is, produced by our tissues, and we do have protons, which is also produced by our tissues. But is this a helpful mechanism, normally speaking? Yes, it is. Because where is the CO2 released, right? Is it released? Is it produced by the lungs and by the alveoli? No, it's produced by the tissues, right? When it's produced by the tissues, we can go to this side again. When it's produced by the tissues, when the CO2 is produced here, what is going to happen to the hemoglobin? The CO2 is going to bind to the hemoglobin, and the hemoglobin will decrease the affinity for oxygen. And because it decreases the affinity for oxygen, it will cause a dissociation of oxygen, right? So the CO2 here actually eases the dissociation of oxygen so that more oxygen can enter back into the tissues, okay? And the H plus is the same, right? The CO2 would come here, it will increase the H plus will bind to the hemoglobin in the RBCs, and that would also facilitate dissociation. So this is a really fantastic mechanism which will ease dissociation, obviously, along with the difference in partial pressure of oxygen, which I've already discussed. Okay, and the opposite is also true. That is at the lungs, right? Instead of, for example, at the lungs, in the lungs we have the alveoli instead of the tissues, and in the alveoli, okay, we have, what do we have? We will lose the CO2. When we lose the CO2, normally what is CO2 doing to the hemoglobin? It's decreasing the affinity for oxygen. When the CO2 itself leaves, it's going to increase the affinity for oxygen by the virtue of it going away, and that would allow for the hemoglobin in the pulmonary, the alveolar capillaries to pick up the oxygen from the alveoli. Okay, so yeah, that's why it's so helpful, right? Now, the third effect is obviously of temperature. Temperature will cause conformational change in the structure of the hemoglobin, and which results in decrease in affinity and will cause a right shift, right? So all these three mechanisms, they come into play, especially during exercise, right? Because during exercise, you'll have an increased body temperature, you'll have increased production of CO2, and obviously increased production of CO2 will increase production of H plus. H plus is also produced as a result of lactic acidosis. And all of these would make sure that there is an increased delivery of oxygen to the tissues. All right. The last one, the last effect, which causes right shift, is the 2,3-bisphosphoglycerate. 2,3-bisphosphoglycerate is normally produced in the RBCs from glycolysis, okay? It's produced in the RBCs as a result of glycolysis. Now, it will bind to the hemoglobin and will decrease the affinity for oxygen and will cause a right shift. Very simple. Now, one of the cases where you will have elevated 2,3-bisphosphoglycerate is high altitude, okay? This is thought to be the case, at least. High altitude would result in hypoxia, okay? Because of hypoxia, there will be an increased glycolysis within the RBCs. Because of increased glycolysis within the RBCs, you will produce a lot of 2,3-bisphosphoglycerate. Because you produce a lot of 2,3-bisphosphoglycerate, that would decrease the affinity for oxygen and will cause a right shift, which is great, right? Because our tissue is, or we are hypoxic and we are not saturating the oxygen enough, we need to make sure that there is more dissociation than normal to make sure that the tissues are well oxygenated. All right, I hope that's clear. Now, this is another curve that is mentioned in your slides, and it looks similar, but it's different because although on the x-axis, we still have the partial pressure of oxygen, on the y-axis, we have the concentration of oxygen in the blood, okay? Not the saturation of hemoglobin, the concentration of oxygen, all right? And here we have two curves, or two lines, should I say. This represents the physically dissolved oxygen, and this represents the chemically dissolved, which is mainly the oxygen which is bound to hemoglobin, right? So the idea is as you increase the partial pressure of oxygen, you're going to increase the concentration or chemically bound oxygen to hemoglobin, and you're also going to increase the concentration, which is physically dissolved. The difference is the physically does not have a saturation. It just keeps on increasing. Whereas the chemically bound, it reaches a saturation, okay? The way to find out the chemically bound at any point would be you take the 200, for example, from here, and you subtract it from whatever is physically dissolved to get the amount of chemically bound. And obviously, this is the saturation point, which is the maximally chemically bound oxygen. So yeah, that's as far as that curve is concerned, right? Now we're going to talk about the causes of left shift, right? The causes of left shift are just the same as right shift in the sense that it will be the opposite, right? We talked about increased H plus, decreased H plus. We talked about increased CO2, decreased CO2. We talked about increased temperature, decreased temperature. We talked about increased the bisphosphoglycerate, the decrease in that. That's it. Additionally, we're going to talk about two causes, which is carbon monoxide and methemoglobin, right? So let's get into it one by one. So first of all is carbon monoxide, right? So carbon monoxide is a very interesting gas, right? It's a poisonous, right? We usually consider it poisonous, right? There are two sources where we find it. For example, it's cigarettes. Don't smoke, guys. Cigarette is one, and the other is car exhaust, right? Car exhaust is another one, and the other one is cigarette. Okay, so what does the carbon monoxide do? Carbon monoxide, actually the hemoglobin binding site, they have a high affinity for carbon monoxide as compared to the affinity for oxygen. So carbon monoxide would want to bind to the hemoglobin over oxygen. So if you have equal amount of carbon dioxide, equal amount of oxygen, carbon monoxide is going to beat the oxygen to bind to the hemoglobin. All right. That is a problem in and of itself. Why? Because it will decrease the oxygenation of the hemoglobin. So therefore, there's less concentration of oxygen being carried by hemoglobin. That's a problem, right? Because that can decrease the oxygen delivery to the tissues because you have less oxygen to begin with. But where does the left shift come into picture, right? We're just taking place of oxygen. How is it, increasing the affinity? Well, the trick is that, let's say carbon monoxide binds to the hemoglobin sites, right? So let's say you have 4 hemoglobin binding sites, and carbon monoxide occupies 2 of them, and it leaves the 2 empty, right? Let's say there's not enough carbon monoxide, and it leaves the 2 empty. So the oxygen can go and bind to it, okay? The oxygen does go and bind to it. What the carbon monoxide does is that once the oxygen binds to it, the carbon monoxide will increase the affinity for oxygen, such that now, once the oxygen is bound to the hemoglobin cannot let go of oxygen. This is a huge problem, right? Although it's increasing the affinity and sounds good, but because it cannot let go of that oxygen, it will decrease the oxygen delivery to the tissues. So you see how it is, affecting oxygen delivery through 2 methods. The first one is that it has a high affinity for hemoglobin, so it will take place of oxygen. And even if it doesn't take place of oxygen, it will make it more difficult for the oxygen to dissociate from hemoglobin. That both of them will compromise the tissue delivery of oxygen. What is the treatment for carbon monoxide poisoning? We give hyperbaric oxygen. Hyperbaric oxygen essentially means, so we have 21% of oxygen in the inspired air. We make it 100%, okay? And that would increase the inspired oxygen's partial pressure will increase. That would increase the alveolar, and that would increase the partial pressure, which means more oxygen, and that could, for example, push away the carbon monoxide from the binding site. Okay, so that's as far as that is concerned. This is a graph which Dr. Shams has mentioned, so I thought I should put this here. So here, essentially, it's the concentration with the partial pressure curve. So this is the normal blood. So I want you to focus on this first, and then have a look at this, right? So this is a half oxygen carrying capacity curve, right? So here, there's no carbon monoxide. Forget about carbon monoxide. Here, there's anemia, okay? So you don't have 50% of the hemoglobin, as you normally do. Because you don't have 50% of the hemoglobin, the concentration is going to cut by half, okay? So it's going to decrease. Because the concentration is going to decrease, well, you're going to get this curve, right? Now, this curve is not in the presence of 50% anemia, okay? It's in the presence of 50% carbon monoxide. But you see how it decreases the concentration of oxygen which is being carried. Why? Because it has a high affinity for the binding side of hemoglobin. So therefore, it will decrease the concentration. That's one. But also, see how it causes a left shift as opposed to the 50% anemia. This is because of the increased affinity for oxygen, okay? It doesn't let go of oxygen. So it's like a double whammy, right? And yeah, so that's as far as that curve is concerned. Now, another cause is methemoglobin. Okay, so what do we mean by methemoglobin? Normally, we have, this is the normal structure of hemoglobin. Okay, so we said that the heme contains the Fe2+, right? The Fe2+ is the one which can bind to oxygen. If due to some reason, due to some oxidant, okay, oxidant, all right, which will oxidize Fe2+ to Fe3+, we get Fe3+. The Fe3+ can no longer bind to oxygen. Because it no longer binds, it will decrease the oxygen carrying capacity, but also it will increase the affinity at the same time, okay? So it will also increase the affinity of at the same time, right? Now, the Fe3+, normally, we do have some amount of, hemoglobin, which exists in the form of Fe3+, because of oxidants in the atmosphere and so on. So the Fe3 plus normally is reduced back to the Fe2 plus form by enzyme known as methemoglobin reductase. Okay, that's not an issue if the oxidation is normal. But let's say due to one reason or the other, there's excessive oxidation plus. So excessive oxidation of Fe2 plus is going to overwhelm the enzyme, the methemoglobin reductase, and will result in excessive formation of Fe3 plus. And the hemoglobin, which contains the Fe3 plus, is known as the methemoglobin, right? And will have a, it will have a problem with binding to oxygen. Okay, so that would decrease the oxygen delivery, but at the same time, it would cause a left shift, right, by decreasing the unloading of oxygen from the hemoglobin. This is similar again, kind of to the carbon monoxide as well. Okay. All right. So this is just an overview. These factors which cause left shift. Same the right shift but reverse, addition to carbon monoxide and hemoglobin. And the right shift causes are increased proton, partial pressure of carbon dioxide increase, or increased temperature, or increased 2,3 bisphosphoglycerine. All right. Now, I know this is a long lecture, but what's important is to understand. Okay. Now, let's start with the carbon dioxide transport. Just like oxygen transport, carbon dioxide is transported through many different mechanisms. The first one is similar to oxygen, it's physically dissolved. Second one is bicarbonate, and the third one is bound to proteins. Okay, this is mainly hemoglobin. Right, bound to proteins, mainly hemoglobin. We're going to talk about this. The majority of carbon dioxide is transported by the bicarbonate route. Okay, so we'll get into the details. All right. So this is the idea, right? You're going to get carbon dioxide from the tissues. The carbon dioxide is going to move into the plasma, right? Within the plasma, the carbon dioxide will combine with water. It will combine with water to form bicarbonate and protons, right? And this is the bicarbonate buffer system. Okay, the equation, very important to know. So it's going to form the bicarbonate and proton. So you're going to say, okay, we get the carbon dioxide and we're going to convert to bicarbonate. Okay, that makes sense why a lot of the carbon dioxide is transported in the form of bicarbonate. But that's the tip of the iceberg, right? Once you go within the erythrocyte, this is what happens. Carbon dioxide moves into the erythrocyte. It's going to combine with the hemoglobin and the water. And also it's going to form the same thing, bicarbonate and proton, the same thing. But the difference is here in the erythrocyte, you're going to have the enzyme, which is carbonic anhydrase, whereas this is not present in the plasma, present in the RBC. What's the difference as a result of the enzymes? We know the enzymes, they will catalyze the reaction. They will just make them fast, like really, really fast, okay? So here, the bicarbonate which is produced will be, produced really fast. And the bicarbonate which is produced will leave the erythrocyte through a channel called the bicarbonate chloride exchanger, which will bring in chloride for pumping out bicarbonate. And that will increase the bicarbonate in the plasma. Again, a major route for the transfer of carbon dioxide. And the other trick is here. What will happen to the equilibrium when you increase the excretion of bicarbonate or removal of bicarbonate from erythrocyte? It will cause a right shift. It will form more bicarbonate and more and more and more. As it forms the bicarbonate, it keeps on leaving. It keeps on going to the plasma. And that is how a lot of the carbon dioxide will persist in the form of bicarbonate, representing the majority of the transport of carbon dioxide, right? And this is here, as you can see here, is the protein transfer as it binds to the proteins. We're going to talk about it in a bit, okay? So I hope that's clear. Now, what do we mean by the carbon dioxide as bound to proteins, okay? So carbon dioxide can bind to different types of protein, and R is just, represents the different types of proteins. And this is the amino group, and it will actually bind to the NH and form the carbamate, okay? And this represents a route through which carbon dioxide is transported. The most important R, or the most important protein, is hemoglobin. Okay, that is important. Now, we talked about the fact that when carbon dioxide binds to the hemoglobin, it will decrease the affinity for oxygen. Okay, it will increase the dissociation of oxygen. But there is an opposite effect. Okay, let's say that, I don't know, carbon dioxide and proton are already bound to the hemoglobin. okay? And then oxygen comes in and binds to the hemoglobin where it wasn't previously bound. When oxygen comes and binds to the hemoglobin, guess what? It will decrease the affinity for CO2 and proton. Okay, it's like taking its revenge now, right? Doing the opposite on the carbon dioxide. It decreases the affinity for carbon dioxide and proton. Okay, and this decrease in affinity in carbon dioxide binding or dissociation of carbon dioxide as a result of oxygen binding is known as the Haldane effect. Known as the Haldane effect. Okay. Now, this Haldane effect that we talked about and the Bohr effect that we talked about are both important in normal regulation of gas transport. We talked about the effect of Bohr. We talked about the Bohr effect in the tissues, right? We said, you have carbon dioxide which comes in from the tissues, and this carbon dioxide will produce the protons, and this proton will decrease the affinity and allows for dissociation, favorite dissociation. Great. What about the Haldane effect? The Haldane effect is important at the alveoli, right? Oxygen comes in from the alveoli and binds to the hemoglobin, okay? Hemoglobin might also be carrying CO2, right? Because we loaded a lot of CO2 at the tissues. Once it binds to the hemoglobin, the oxygen, it will decrease the affinity for CO2 and proton. It will allow for increased dissociation of protons, so that more and carbon dioxide, so that more carbon dioxide is blown off. It moves into the alveoli and blown off. And this is important alveoli. Okay. Okay. Bohr effect, important at the tissues sites, tissue exchange, and the Haldane effect is important at the alveoli. All right. Now this is the CO2 dissociation curve. Okay, so this is the CO2 concentration and the partial pressure. Again, we have two curves. We have the chemically bound and we have the physically dissolved. Physically dissolved does not have a saturation point, similar to how physically dissolved didn't have it in the case of the oxygen dissociation curve. But here, the chemical bound also doesn't have a saturation point. Why? Because the majority of it is not carried by hemoglobin. Majority of it is carried in the form of bicarbonate, right? And you can, as we saw in the erythrocyte, you can continuously produce more and more bicarbonate, right? And that would result in the lack of saturation point, okay? Lack of saturation of the curve, right? Okay, so another thing I want you to focus on is the steepness of the curve, similar to what we mentioned for oxygen. So for example, when you look at this partial pressure of CO2, okay? So the partial pressure of CO2 changes by very little amount, but the concentration would decrease way more, okay? So the concentration changes to a significant degree, but the partial pressure will change very minimum, okay? Very minimum, right? So this is another thing that you should focus on. All right. We are now going to get into the things which we call right shift, apart from one, okay, which is again H+. H+, talked about it. It will cause a right shift in the oxyhemoglobin dissociation curve. It will also cause a right shift in the carbon dioxide dissociation curve. Increased proton will result in a right shift, okay, and so would an increase in temperature. Why? Increase in proton, you can use the bicarbonate buffer again to understand it, right? You're increasing the proton. As a result of it, you're going to shift the reaction towards the CO2, right? Towards the formation of CO2. And when you form CO2, you're going to essentially dissociate the CO2 more, right? In the gaseous state, because we want it to be in the state of bicarbonate, right? We're decreasing that and we're increasing the amount of gaseous form of CO2 so that it can be released, right? Also, an increase in temperature would also cause a right shift. All right, now time for a question. So here we have a 58-year-old man, right, with a history of chronic obstructive pulmonary disease, which presents with clear shortness of breath, reductive cough, confusion. Arterial blood gas showed PaO2 of 55, PaCO2 of 60, pH was 10.28. He had the respiratory acidosis. The acidosis resulting in a rightward shift of oxyhemoglobin dissociation curve. Which of the following mechanism explains the right shift and the decreased affinity of hemoglobin for oxygen? Okay, let's see. What do you guys think? That's right. It is C, right? And that makes sense, right? Because proton binding would cause a conformational change. binding of proton will not increase the affinity. Decrease in temperature will increase in temperature will promote, not decrease. And the binding of oxygen to hemoglobin will enhance CO2 binding. Again, completely incorrect. It will enhance the CO2 dissociation. So yeah, that's what makes the most sense. So the correct answer is C. Now, finally, we are going to cover the last lecture, which is, not much. So inshallah, it's going to be quick. So hypoxia, right? So what do we mean by hypoxia? Hypoxia means lack of oxygen, right? The fancy way to say lack of oxygen. So there can be two types of hypoxia. There can be tissue hypoxia, or there can be hypoxemia, right? So when we say emia, anything emia, it usually refers to the blood, right? Hypoxemia, hyperemia, things like these. Hyperemia, for example, includes blood supply. So increase or decrease, of anything in the blood. Okay, so this is hypoxemia, all right, or arterial hypoxia. The difference is in tissue hypoxia, PaO2, which is the partial pressure of oxygen, is surprisingly normal. We're going to talk about the cause. As in hypoxemia or arterial hypoxia, the PaO2 is. All right, now let's get into the causes of tissue hypoxia. Tissue hypoxia can be stagnant, can be anemic, or can be hypotoxic. What do we mean by stagnant hypoxia, right? So what do we mean by stagnant? Stagnant is something which is still, and it's not moving, it's just there, okay? And that is referring to the blood supply. When you have adequate oxygenation of blood, but the blood supply is compromised to the tissue, okay? So this could be, for example, vasoconstriction, which can happen due to many different conditions, diabetes, and so on, okay? I'm going to get into the different causes, but the idea is that you have decreased blood supply, normal oxygenation of the blood, but because of the decreased blood supply, the oxygen delivery is impacted. As a result of which, you have hypoxia, simple. And the PaO2 is normal, right? Anemic hypoxia, anemia would result in what? Would result in decreased amount of hemoglobin. You have decreased amount of hemoglobin. When you have decreased amount of hemoglobin, you will carry less oxygen, okay? And if you carry less oxygen, you will deliver less oxygen to the tissues, okay? But why is the PaO2 or the PO2 or the partial pressure of oxygen in the blood normal here? All right. It goes back to the principle that we discussed. The oxygen which is bound to the hemoglobin will not contribute to the partial pressure of oxygen, only the physically dissolved does. So even though you have anemia, even though you don't have the adequate amount of hemoglobin, the blood is still becoming oxygenated. Why? Because of physical dissolution, okay? So yeah, that's anemia. Other one is histotoxic. So histotoxic hypoxia can happen as a result of cyanide poisoning. Okay, as a result of cyanide poisoning. So here, the same idea that PO2 is normal, but because of poisoning, because of, for example, cyanide and whatnot, it can result in decreased oxygenation of tissues. Right. Now, arterial hypoxia or hypoxemia. Again, what happens here is that the PaO2 decreases. So the first cause we're going to talk about is low inspired PO2. Okay, we talked about this, is high altitude. We talked about it multiple times throughout the lecture. High altitude would mean there is decreased pressure of oxygen. When you have decreased pressure of oxygen, you will not have enough physical dissolution because you have less partial pressure of oxygen to begin with. Okay, and that would cause hypoxemia. Obviously, it will affect hemoglobin oxygenation. The fact that it affects the partial pressure of oxygen is enough for us to say that it's hypoxemia, right? Yeah, diffusion limitation. Okay, so diffusion limitation, this was covered in previous lectures. I'm not going to go into details. So essentially, diffusion limitation is that, look, usually it could be that the alveoli and alveoli is well ventilated and the blood supply is fine, but because of some problem. So ideally, we want it to be 100 here, and we want it to be 100. But because of a problem with diffusion, it doesn't happen. So it doesn't happen. It doesn't become equilibrated as well. So instead of being 100, I don't know, it's lower, okay, like 80 and whatnot, right? That's diffusion limitation. The last one is hypoventilation. For hypoventilation, we need to understand the normal ventilation. So again, the inspired partial pressure of the inspired O2 is about 150, and by the time it comes to the alveoli, it's about 100. Okay, and the blood as it's coming in, we talked about it, is 40, and the, let's say, PCO2 is 45. It's going to come here, okay? Oxygen is going to move in, carbon dioxide is going to move out. Oxygens, okay, the oxygen positive pressure in the pulmonary venous blood would be, venous blood, okay, horrible handwriting, I know, would be 100, right? Okay, and the PaCO2 would be lower, I don't know, 40, let's say, for example. Okay, PaCO2 would be 40. All right. Now, look at this, okay? So this is talking about the arterial PaO2. It's saying it's 90. Wait a minute. So we said that the pulmonary venous blood, it will be 100. By the time it gets to the left ventricle, by the time it gets to the left atrium, to the left ventricle, and it goes into the artery, and we measure it, it's going to be 90. What is the cause of this mismatch, or what's the cause of this decrease in partial pressure of oxygen? We talked about it, right? We talked about the physiological shunts. We talked about, the Bayesian veins. We talked about the bronchial veins, and these are, one of the few factors which are responsible, a few of the factors which are responsible for the decrease in partial pressure of oxygen. All right, and this is normal, by the way. So you have 100 here, you have 90 here. This is perfectly fine. All right, and this is hypoventilation, which can happen as a result of airway obstruction. So you have PiO2 is normal, okay, 150, but because of obstruction, instead of being 100, it's 80, okay? Because it's 80, very simple, the PaO2 in the arterial blood is also going to be, 10 millimeters of mercury lower, so 70. Because it's 70, it's basically, that's what defines the hypoxemia, right? The last one is right to left shunt, which we talked about, right? Which is talked about, for example, there's physiological and there can be also pathological, and the pathological would result in hypoxemia, right? As far as the last one is concerned, I am not going to cover this. This is going to be the next lecture. And yeah, that will be all. And this is the final question. Okay, so again, you have a 25-year-old man recently returned from a mountaineering trip in the Himalayas. Okay, complaint of headache, dizziness, shortness of breath, during exertion, examination. He appears mildly cyanotic. His arterial blood gas analysis shows PaCO2, PaCO2 is blah, blah, blah. Which of the following represents the most likely cause of hypoxemia in this patient, right? So what do you guys think? Yes, it is D, right? This was a fairly straightforward question. And yeah, that will be all. Thank you very much. This is the code. You could give any feedback if you have any for me. I would appreciate it. And there are some extra questions here which you could solve to test your understanding. And does anybody have any questions? Thank you. Thank you. Thank you.